Ann Arbor Inclusive is produced in part with the Ann Arbor Commission on Disability Issues and CTN. The views and opinions expressed in the show do not necessarily reflect the views and opinions of the Commission or CTN. For more information about the Commission on Disability Issues, visit a2gov.org/disability resources. If you have program topic suggestions, please email a2disabilityissues@gmail.com.
Hi, thank you for tuning into Ann Arbor Inclusive. We are a program of the Ann Arbor Commission on Disability Issues. I'm Tom Holtland, and I'm your host. There are nearly 3 million people in the world that live with MS. And in the US, it's reported that there are 200 cases diagnosed in just a week. So we are lucky to have Dr. Medeiros with us, who is the president of the Michigan Institute of Neurological Disorders, and that their acronym for that is MIND, M-I-N-D. So instead of telling you what the center does, Dr. Medeiros is way more qualified to tell us what they do, but a lot of groundbreaking research has led to really astounding treatments and so forth. So Dr. Medeiros, welcome to Ann Arbor Inclusive.
Thank you very much for having me. I appreciate it.
For sure. Yep. We will note that your center is in Farmington Hills. So the main center is right here. But why don't you tell us a little bit about yourself, maybe some of your background, and then we'll go from there and learn about the center.
Yeah, thank you for having me. So just as a quick background, went to undergrad and osteopathic medical school at Michigan State, and did my neurology training at, used to be called Botsford Hospital in Farmington, and it is now part of Corewell Health, or used to be called Beaumont Farmington Hills. Okay. And then I subsequently took over the residency and became the program director. And although I'm not the program director anymore, I still assist with running the program, and I'm actually still making rounds with the residents twice a week. Okay. But then back at Mind, so I wear a few hats. Yes, as you had mentioned, I'm the president of the company. I also assist Dr. Belkin, who's our MS director, with the MS infusion center, and actively participate in research, and now run the neurology department over at again, formerly Botsford, Beaumont, Farmington Hills, or now what we call Corewell Health.
Okay, all right. So why don't we jump right in? And I know that your institute was founded in 1969. And we can tell by looking at you that you weren't part of that crew. But
appreciate that.
Yes. Why don't you? And I was very young too. So why don't you tell us your best description of what Mind is?
So Mind is a private center that really is all encompassing. We treat all neurologic diseases. Our main office, as you said, is in Farmington Hills on Orchard Lake between 12 and 13. We do have satellites right now. One is at Roseville, and the other is in Dearborn Heights. And we have, a large group of neurologists, as well as extenders, nurse practitioners, and PAs. And so we are fully equipped to handle any disease process from start to finish. And what that means is we have our own diagnostic center. So if a patient needs MRI testing, direct follow-up with the patient, same day or not, we're able to do that. We can certainly get into the infusion products, but we have our own infusion center. So vast majority of that is the multiple sclerosis meds. So patients can literally come in, get an MRI at 7 o'clock in the morning, come right upstairs, see me, go over the MRI with them right on the spot, and then they walk right to the back infusion center and get infused. So we're pretty proud of the ability to do all these things under one roof. Super convenient. for the patients, and frankly provides excellent care.
Kind of like a one-stop shop.
It is a one-stop shop model as best that it can be. Yes.
Yeah, yeah. So tell us, where does your passion come from for working with people with neurological disorders and helping create a good quality of life for folks that live with these different disabilities? Where does that come from? Where did it come from you?
Well, I think when you look back at why you chose a certain profession, right? You're not only intrigued by the disease process itself, but you're intrigued by, what therapeutics are out there. And truth be told, many, many years ago, the nature of neurology is you did not have a lot of really good therapeutics. Many years ago, it was diagnosis and prognosis and very little in the treatment realm. So, what's exciting now is, and this is not just the MS world, this is in the migraine world, this is in the Parkinson world, this is in the dementia world. We continue to have this explosion of medications that we've used in clinical trials, and now we're using in commercially, and we're seeing just huge success stories in slowing disease processes down. So really, I think what it comes down to is it's the evolution of the neurosciences that makes it exciting.
Yeah, for sure. There are a lot of things that when you say neurological disorders, there are so many things that fit under that. So why don't you tell us what specialty areas does Mind focus on?
Right. So as I said at the beginning, we're an all-encompassing facility. So we have a core group of neurologists who are considered general neurologists. So they will see every neurologic complaint, neurologic disorder. And for 90% of those patients, they're handled very, very well. Okay. But then if you look at the subspecialties, so for example, we have a movement disorder center of excellence. So one of my partners is a fellowship trained Parkinson expert. So he will see our Parkinson patients or our essential tremor patients. We do Botox for what we call dystonia. So again, most of us see Parkinson's, but we have that subspecialty arm if we need it. Okay. Same with headache. So one of our partners is a fellowship trained headache expert. She's outstanding, trained locally, and then did her fellowship in Ann Arbor. And so when we get into a refractory headache case, whether it be head pain, facial pain, we'll often ask for her input. And then similarly, where I work upstairs in the MS center, although all of my partners feel comfortable dealing with MS, sometimes it gets a little bit more complicated. And then they'll ask for our opinion upstairs and move the patient into the MS center. So, movement disorders, headache, dementia, MS. We also have a pain management service. So we have a neuroradiologist as well as an anesthesiologist. Say you have a pinched nerve, herniated disc, we will do the epidural injections in the office.
Okay. Personally, I have a spinal cord injury that is complete at T2. And so do you see people with spinal cord injuries, specific spinal cord injuries, without some of the disorders and disabilities you've mentioned?
Yes, absolutely see spinal cord injury patients.
Okay. All right. So people can be referred to you for that.
Absolutely.
Great. So let's see. Why don't you explain, since multiple sclerosis is really one of your main patients that you see, can you tell us a little bit about what it is, what MS is?
Yeah, it's a great
what causes it?
I'm sorry, what was the second part?
And what causes it?
Yeah, so it's not an easy answer. It's a complicated answer because at the end of the day, we still don't know with 100% certainty. But I think that in general, it is very well accepted. Well, first of all, we know that MS is an autoimmune attack, right? So your own body is attacking itself. And MS is a central nervous system problem. So the central nervous system is comprised of the brain and the spinal cord. And so MS lesions on an MRI, for example, look like little white spots, little clouds. And those are pockets of inflammation. Okay, so there's this autoimmune attack on your nervous system. And really the most acceptable theory is that this was triggered by some sort of infectious process, maybe when you were younger, presumably a virus, right? Which virus, we don't exactly know. There's a lot of data that continues to suggest that the monovirus, the Epstein-Barr virus, is one of the triggers. But that's the basis behind it, is that viral exposure, some pathogen, and then that throws this autoimmune cascade into effect, and therefore your own body is working against itself, and it's creating all these little, what we call demyelinating lesions, which are what MS lesions are.
So is it much easier to diagnose multiple sclerosis than it has been in the past?
Oh, with 100% certainty. So, many years ago, when you didn't have MRI technology, and fortunately I was not practicing then, you were relying more on history. Your physical exam is always important, but you were really looking at history and, frankly, spinal fluid analysis, even though that was not definitive. And then as MRI technology came about, you're now able to see these lesions. And today, the MRI technology is so good that you're picking up lesions that you would have never seen many years ago, especially in the spinal cord. The first generation MRIs were never good for spinal cord disease. And now you're seeing more and more MS on the updated MRI. So unless somebody is in a gray area or I'm not 100% sold on the diagnosis, frankly, the amount of spinal taps that we do now are way down. If you've got excellent clinical history and you've got supportive exam findings and MRIs, it's a much easier diagnosis to make in this day and age.
Okay. So my mother lived with MS for 50 years. And so it goes back quite a ways.
Yes.
And it took a long time for them to agree and say, yes, this is progressive multiple sclerosis. What other kinds of MS are there if it's not progressive?
Right. So if you go off of statistics, right, roughly 80% of patients at the time that they're diagnosed have what's called a relapsing remitting. So, perfect example, a 20-year-old female develops what's called optic neuritis. So there's painful vision loss in one eye, and that lasts for 3 weeks. And then that goes away. And maybe she's good for 2 years, and then she develops numbness from her waist down for another month. And then that goes away. And then another event. So you get that kind of relapse remit. So that is by far the vast majority of people at time of diagnosis. Okay. Half of those patients untreated will go on to develop what's called secondary progressive MS. So these are people that can still have relapses, as I had mentioned, but the amount of relapses is significantly decreased, may not even exist, but yet their level of disability is going up.
Okay.
So the whole purpose of all these disease modifying therapies is, right, we can reduce your chance of having an attack, we can keep your MRI stable, and those two things lead to less disability over time.
Okay.
So that's the vast majority of people. There's a small subset, roughly 5 to 10%, who have a progressive form of MS right off the bat. Most of these are in what we call the primary progressive state. So these are individuals that we may interview, and we may give these examples of attacks that come and go, and they've never had one of those. They simply have a problem. For example, maybe it's their gait, leg weakness, spasm, trouble walking, never have an attack that comes and goes, and that slowly gets worse over time. But
Okay.
that is by and large the minority of patients. The vast majority start out as a relapsing remitting process.
Okay. Yeah, because I've known people that say I have MS and they appear to be, they appear to be very able-bodied, and they explain, well, I'm in remission now.
Yeah.
In that remission, it sounds like from what you're saying, can last a lifetime or a short period, right?
Yeah, so relapsing disease can be very unpredictable, which again is in this day and age, we have so many excellent high efficacy meds that if we get to a diagnosis quickly and we get people on the newer, more aggressive therapies, you've essentially put a halt to the disease. Now, someone that's living with MS for 30, 40, 50 years, as you can imagine, we didn't have disease modifying therapies.
Correct.
And so by default, they've entered into a progressive state, and there's really not really great medication once you get to that point. You have to stop the inflammatory process at the beginning, put a halt to it, and that leads to less disability over time.
Okay. My mom went through the stages exactly how you explained them. She had to wear an eye patch for a period of time when we were little, and then it was then a drop foot developed, and she ended up going from using a cane to a walker to a wheelchair. So we watched the progression up close and personal.
Right. So if your mom was diagnosed today, right?
Yes. Yeah.
At onset, she would go on a highly efficacious medication and all these other things that you witnessed over time. Not to say it can't happen, but
Yeah.
the chances of those happening are very, very unlikely.
Wow. So let's jump right to the medications that you, the groundbreaking, the newer medications, the infusions that you've mentioned, and the unique part of it being that you were part of the clinical trials to bring those medications to be FDA approved. Can you tell us a little bit about that?
Yeah. So if you go back to when I was in training, the groundbreaking medications that came about then were old, as we call them, the subcutaneous injectable medications. And as a group, they would decrease your chance of a relapse by, say, 30%. So, when you go from no drugs to that, at that time, that was pretty impressive.
Yeah.
Now, saying that, you then dealt with a lot of bad side effects to injectable medicine. So we slowly moved, and we have some oral therapies now, pills that work. Some are mild, some are more aggressive. But really, the infusion therapies, it work exceptionally well. So we really have two main types of infusion therapies. Natalizumab is a drug that we infuse once a month. We were actually involved in the pivotal trials that got that drug approved. And it literally puts a halt to the disease. You don't see MS attacks. You don't see worsening MRIs. And in fact, because of that, you don't see significant progression to disability. I mean, it works that well. And then the second group is a group of what we call B-cell therapies. These are a little different. And these are infusions that are twice a year. So, for some patients, boy, that's kind of a hard argument, right? Coming in twice a year and getting an infusion is how convenient, right?
Yes.
So that's kind of the cornerstone of the infusion products.
Okay.
And I would say, at least in our center, we probably use that group of meds the most. Okay.
All right. What is the sort of the age range of people that are diagnosed with, let's talk about MS. What are the ages that you mostly see, or what are the stats on that?
Well, it's a young person's disease, right? So every day here we're diagnosing somebody that may be, late teenager, early 20s, late 20s. Now there are patients who, you're young and you have some sort of neurologic attack, and because it got better, what do? You often ignore it. So sometimes we're diagnosing people a little bit later on in life, but then as you start to examine them historically, you realize there may have been 2 or 3 attacks before they even got to the doctor.
Okay.
So in general, a younger person's disease, that does not mean we're not diagnosing people in their 40s and 50s, because we are.
Right. Yeah.
But as you look back, many people will go home and say, oh, in retrospect, I had this happen to me.
Yeah.
I ignored it.
Yeah. Or they didn't know what caused it.
That's right.
Depending on where in the country or where in the world you are, and the access to good physicians like the physicians at Mind. So
100% of it. Yeah, you are exactly right. I mean, there are people that, maybe they don't have access, right? Maybe they went to a primary care physician, and because the symptoms were better, they chose not to order any testing.
yeah.
So
I'm really surprised to hear you say that it's a young person's disease. I had no idea that the majority or large number is happens in your 20s. I know you just said
and younger.
Wow.
Yeah.
Younger than 20, like in their teens.
Well, this is at onset of diagnosis, right? I mean, any particular day in my clinic, I may have 50, 60, and 70-year-olds who have MS, but that's not when I diagnose them.
Yeah. It's amazing that if you can catch a diagnosis of MS as a young person, say a 20-year-old, and some of your drugs are, halting that in its tracks, is just amazing.
Yeah, there's a terminology, we call it NEDA, N-E-D-A, no evidence of disease activity. And this is something that is followed in these clinical trials now. So, again, the perfect person is a young person who presents to you after, say, 1 or 2 clinical attacks, and they've got a pretty significant lesion burden. So maybe they've got a couple lesions in their brain, but they also have a couple in their spinal cord. So, those are people that you don't want to start with the milder drug.
Right.
You bypass those. You get these people on the most aggressive therapies at the beginning, and down the road, if you want to peel back, if you want to de-escalate their therapy, that's something we can talk about. But the way that we treat MS now compared to how we used to, the aggressive therapies go first.
Okay. All right. I believe that Mind was recently one of the first in the state to infuse a new drug. Is that the one that you just mentioned?
So I think you must be referencing one of the B-cell therapies, Briumvi. So okay. I don't know if we would have been the first in the state, so I don't want to misspeak. We could have been the first private facility to infuse it. So
that's what it was.
Okay, yeah. So Briumvi is one of the 2 products that I was telling you about, is twice a year. And yeah, so again, the more options that I have available, the more options that I can give to the patient. And, we make the choice together, right? I don't tell a person you're going on drug A, but I want them to be educated, and I want them to make an informed decision. So I may say to them when I make the diagnosis, based on your MRI lesion burden, based on your age, based on what you do for a living, I would look towards these 2 or 3 drugs, and then we'll literally give them educational material on them, have them go home and digest it, and then they can come back and we can have an educated decision.
It kind of reminds me of how chemotherapy treats patients with cancer. You're doing it for people with MS, and while it's not chemotherapy, it sure sounds like that its efficacy is very good. And,
well, it's interesting because it's actually a very good analogy. because it is the exact same, right? I mean, we're picking a drug and we're following it based on MRIs and clinical, no different than, for example, an oncologist would follow a PET scan or a CAT scan. And in fact, well before these new infusion products, we were actually giving chemotherapy.
Wow.
Yeah. So, chemotherapy is an immunosuppressive agent, and we have an autoimmune attack. In fact, not long ago, we had a pretty significant case of a very malignant MS type picture that ended up in the hospital. And we, with the help of an oncologist, we actually infused chemotherapy, and she responded extremely well. So it's an interesting analogy you bring up, because I use that in my office all the time.
Okay. Yeah. It's very easy for people to understand, I'm sure, because that treatment's been around a long time. We're almost out of time, so I wanted to make sure to ask where our viewers can learn more about Mind, and do they need a referral? Do they need to call you or their doctor first? Real quickly, can you tell me about that process?
Yeah, so first of all, mindonline.com is our website. Okay. It's a pretty inclusive website. So there's a lot of information on there.
Okay.
But the only referral that anyone would potentially need is if their insurance mandated it, right?
Okay.
So if they had an HMO, their doctor would need to agree to that and send over a referral. But otherwise, we have phone lines that are open. Patients can easily, make an appointment at any of our offices, and pretty much that's about it. It's about as easy as that.
Yeah. I mean, we could go on. I have so many other questions, and because of that, I'm sure I'll go to your website and look at it a little further, because this is personal to me, having a spinal cord injury and having my parent live with MS for so long, and I have lots of friends that have it. So Dr. Banderas, I really appreciate your time. This was really eye-opening for me, and I'm sure it was for our viewers, and maybe we can catch up sometime in the future. But I really appreciate you coming on and talking about Mind and the people that you see, and more importantly, the quality of life that you're allowing patients to have if they have that diagnosis.
Yeah, no, I appreciate you having me. Thank you very much.
You're welcome. Well,
Right.
That's our show for today. You are watching Ann Arbor Inclusive, which is a program of the Ann Arbor Commission on Disability Issues. We thank you for joining us, and we'll see you next time on Ann Arbor Inclusive.